A very good afternoon. I'm Dr. Chee, the Medical Director of Hospital Fatima. This year, we at Hospital Fatima join forces once again with WHO to celebrate the World Patient Safety Day by dedicating a week of activities and programs in line with the theme Safe Maternal and Newborn Care. Approximately 810 women die every day from preventable causes related to pregnancy and childbirth. In addition, around 6,700 newborns die every day, amounting to 47% of all under 5 deaths. Fortunately, the majority of stillbirths and maternal and newborn deaths are avoidable through the provision of safe and quality care by skilled health professionals working in a supportive environment. Hence, this year, Hospital Fatima will be dedicating this week from 13 September to 17 September, focusing on the above theme. We have a lineup of online activities and talks which will be streamed on our Facebook Live. Please do follow our Instagram, Facebook, and website for more information. Thank you and stay safe always.
Good afternoon, ladies and gentlemen. Welcome. Today is the WHO World Patient Safety Day, 17 September, celebrated worldwide, and the theme is Safe Maternal and Newborn Care. I am Akma from the Sales, Marketing and Public Relations Department, Hospital Fatima Ipoh, and I invite you to join us in this event with our final important talk in our series of talk during this Patient Safety Week. And we are very pleased to have with us today Dr. George Chee Pong, our resident consultant of obstetrician and gynecologist who is graduated in the Trinity College Dublin in 1988, being a member of Royal College Obstetrician and Gynecologist in 1993, and resident ONG in Hospital Fatima since 1999. Today, his talk entitled Safety in Pregnancy, where he will share with us his immense expertise and experience on the aspects of safe pregnancy, especially in these times of COVID-19 with our audience today. I am sure you are eager to hear the talk now, which will cover about 45 minutes, and we will have around 50 minutes in our Q&A session immediately after the talk. So, it is my pleasure now to introduce to you Dr. George Chee Pong.
Good afternoon, everyone. My name is Dr. George Chan. I'm a gynecologist obstetrician at Fatima. I've been here since 1999. So I've been asked to give a talk today. And the topic of my talk today is safety in pregnancy, okay, for the mother and the child. So this is in conjunction with the World Patient Safety Health Day, okay? Right. Now, the whole thing about safety in pregnancy for the mother and child really is changed dramatically over the last 1.5, 2 years. The new era of COVID-19. Okay, and this really, the talk really is really focusing on how to prevent morbidity and mortality in both the mother and the newborn. Okay, but the talk I give today will be so different to what I would be talking about, say 2-3 years ago, when we were more inclined to talk about the obstetrics aspect of how to prevent morbidity and mortality in the mother and newborn. But now we really have to add on this COVID factor, which has changed really dramatically in how obstetrics is practiced, how medicine is practiced, and really it has played havoc with everybody's life, and it is affected not only the health but also the welfare of everyone. Right. So I will go through this slowly on how, in this day and age, we should talk about to try and prevent any untoward effects for the mother and your newborn. Right. So before we talk even about pregnancy, we should really talk about pre-pregnancy aspects. Before, of course, sometimes pregnancy is planned, and that would be ideal when pregnancy is planned and everything is in order before one embarks on a pregnancy. But of course, sometimes the pregnancy may be unexpected and unplanned. Okay, now, but let's just talk anyway, as if we know when you are planning to have a baby and everything is to be in good order before we start. So what should we say? For example, we should not really only see the patients in pregnancy, but really before they embark on the pregnancy, they really should visit their doctors and discuss many aspects of their health and what do they expect on the pregnancy they're going to embark on. Okay, first of all, I think good health, nutrition, including dental health as well, is very, very important. We all know that if you're healthy before pregnancy, your pregnancy is likely to be a low risk, and the health of the mother and the baby at the end of the pregnancy and after delivery, of course, should be good. And if, on the other hand, if someone is in poor health with multiple medical problems, needless to say, the pregnancy is high risk, and we expect more problems in pregnancy and in labor and even after delivery, and the outcome may not be as good as if the mother was in good health before. But that is an ideal world when everybody is in good health before they embark on the pregnancy. And just because your health is not ideal doesn't mean you should not be allowed to be pregnant or should not embark on a pregnancy. But then saying that, we of course should optimize everything before you do get pregnant. And if you do have any medical problems or any other problems with your health or anything, really it should be managed and optimized before you embark on a pregnancy. Now, some of the common things that health problems that people do have before they get pregnant, as you know, in this current days, and people are getting married and pregnant at an older age compared to many years ago, when patients got married early and started pregnancy early and delivered many children. But now people have careers they think about, and marriage is delayed, and hence the average age of starting the pregnancy is higher. So as you get higher, there are more medical problems that may crop up. So very often we have to screen for a lot of medical illnesses before we embark on. Now, some of the common things we should really look for is one is thalassemia. There's alpha and beta thalassemia. We should really look for the parents whether they are carriers of thalassemia. Okay, because if, for example, the mother is a thalassemia carrier, then the partner, the husband's blood should also be checked to make sure that they're not both thalassemia carriers. And if they are, there'll be a 25% chance that the baby will have thalassemia major, and this genetic counseling needs to be discussed properly. And thalassemia is actually quite common, especially people of the Malay and Chinese ethnic race. Also, we should screen for diabetes, hypertension. These are also very common in our country. And if you have underlying diabetes or hypertension, it doesn't mean you should not embark on the pregnancy, but certainly you have to make sure that both diabetes and hypertension is well controlled. Now, the medications the patients are on also is very, very important, because many medications needs to be altered in the course of pregnancy. Some medications is contraindicated in pregnancy. For example, ACE inhibitors and such are very commonly used drugs for hypertension, and these are not indicated in pregnancy. Okay, even diabetes, we need to optimize the control, and also they need to have be started on insulin before embarking on pregnancy if their control is poor. Blood investigations are not a must, but it's probably, if the pregnancy was planned, it's not a bad idea. So that will certainly rule out things like thalassemia traits, diabetes, anemia, and certainly we can check on the immunity status of rubella and hepatitis B. And if they are not immune to rubella or hepatitis B, then certainly vaccination can be given before pregnancy is embarked on. Pap smear, if it's not already done, you can be done to screen. Even breast examinations, and because should be examined before they embark, because we do get cases of breast cancer in pregnancy, and it's good to check it before they embark on pregnancy. As you know, during pregnancy, breast examination is a bit more difficult, and before they embark on pregnancy, a pap smear and a breast examination is not a bad idea. Folic acid supplement. I mean, if you're planning on starting a pregnancy soon, it's certainly a very good idea to take folic acid supplement. Folic acid is just one of the vitamin B component, and it's been proven that if you take it before and during early pregnancy, certainly it prevents neural tube defects. And you can just supplement with 5 milligrams a day. You can get it from the pharmacies without a prescription. Okay, now what I'd like to specifically talk about in pre-pregnancy is vaccinations. So please get all the vaccinations in order before you embark on a pregnancy. Of course, like I said, you may not have planned the pregnancy, but it's good certainly if you're planning on the pregnancy, then rubella immunizations, hepatitis B immunizations should be up to date. Now, the new thing I need to talk about now is COVID-19 vaccination. Okay, now I believe that because COVID-19 and pregnancy is a very, very bad combination, and even especially with the Delta variant, the risk of COVID-19 in pregnancy is at least 4 times compared to the general population. So certainly you should need to consider, certainly almost mandatory, that you should be vaccinated fully before you embark on the pregnancy. Okay. In Malaysia, we have Sinovac, AstraZeneca, and Pfizer. All 3 are safe and effective in preventing serious sequelae from COVID. So certainly we should recommend, and in fact strongly recommend, COVID vaccination, full COVID vaccination before embarking on a pregnancy. Now, there are always many patients when I help out in the vaccination centers, when they say, "Oh, I'm planning on a pregnancy, so I don't want to be vaccinated because what if I get pregnant and the vaccine affects my child?" Now, up to date, there's no evidence whatsoever that any of these vaccines that are available here in Malaysia will affect your baby. Okay, so as soon as you finish your vaccinations, you can go ahead and embark on your pregnancy. There's no reason to hold back on the vaccination until you deliver your first, second, or third child, and then go ahead and vaccinate them. I don't think it's really a good idea, because we have seen many bad outcomes to the mother and the baby especially in pregnancy when they get COVID when they're not vaccinated. So certainly vaccination prevents serious sequelae from COVID. So get vaccinated before you embark on the pregnancy. And certainly, I believe that patients that are going for infertility treatments, for example, IVF and IUI, should really be vaccinated before they embark on these treatments. Because it's very, very clear, and more data are coming out on the effects of COVID in pregnancy, affecting both the child and the mother. Okay. Okay. So now, assuming you are pregnant now, so most of you would have um, done a pregnancy test yourself at home and confirmed pregnancy, and you'll be coming to see your obstetrician. So one of the first few things we do after checking on your general health well-being is that we perform an ultrasound. Ultrasounds are perfectly safe. It does not contain any radiation. It's perfectly safe. And we just put a probe in the abdomen, or if necessary, in the vagina, and we can see the fetus. Okay, what are the reasons we need to do an ultrasound in early pregnancy? I think early pregnancy ultrasound is very important. First of all, we want to confirm pregnancy. Okay. Second, we want to confirm the pregnancy is in the uterus. That means you don't have what we call an ectopic pregnancy. An ectopic pregnancy is when the pregnancy doesn't implant into the uterus, but rather in the fallopian tube. And that's very dangerous, and it can rupture in the fallopian tube and cause a lot of internal bleeding, and you need surgery to remove the fallopian tube together with the pregnancy. So ultrasound will be very helpful there to date the pregnancy, because many a times our period, the dates are wrong. We can, because it's important, as you know, to know exactly how many weeks pregnant you are as pregnancy progresses. Also to know how many babies there are, okay, whether you're having one baby or twins. And even if you're having twins, it's very important to know whether the babies, the chorionicity, which is like whether the babies come from one or from two, okay, whether they are identical or non-identical. This is very important because the management and the outcome for identical and non-identical, or monochorionic and dichorionic twins, are very different. Now, the other thing is, as we're talking about safety in pregnancy, we're talking not only about the mother but also the baby. So it's also important to be offering screening to the mother for abnormal fetus. And in the ultrasound scan at 11 to 14 weeks, we can see quite a lot in the fetus to determine whether or not the child is healthy or normal. Okay. We at 11 to 14 weeks we can do what we call the nuchal translucency, which is measuring of the thickness behind the neck. Okay, and by seeing how thick it is, we can actually suspect whether the child is normal or abnormal. Of course, it's not diagnostic, and further test needs to be done. We also look at the nasal bone, because if the nasal bone is absent at this stage, then there's higher risk that the child is abnormal. And these measurements can be complemented by blood tests. Okay, of course, we do blood investigations if it's not already done pre-pregnancy for things like hepatitis, VDRL, HIV, checking for anemia, diabetes. But we can also offer screening for Down syndrome and other chromosomal abnormalities. There are two commonly used tests that I do now. One is the first trimester screen, or the OSCAR. It's basically taking blood from the mother is harmless, and by deciphering it, the levels of certain hormones in the blood, together with the measurements of the nuchal translucency and the nasal bone, the computer will give us a risk of how high the the risk of Down syndrome in the baby is. And of course, a more accurate way of doing it is to do what we call NICC or NIPT, where we withdraw blood from the mother, and from the blood we can get some fetal cells. With PCR, we amplify it, and we can actually know the DNA composition of the baby quite accurately, up to 99.9%. That's a bit more costly, but they're certainly very, very accurate. In fact, many diseases can be screened this way, but of course, not everything is completely screened. The need for amniocentesis now is much less now. I used to do a lot of amniocentesis in the early years, and but now with these screening with NICC and ultrasound, I think we have reduced the number of amniocentesis that we do by quite a large number, and we only use it in certain instances, for example, to screen test for thalassemia, or when the NICC results come as abnormal. Okay, so this is the screening for genetic problems in the fetus. Now, the other thing I want to stress again at this stage in my talk is vaccination in pregnancy. Okay, vaccination is perfectly safe in pregnancy. Okay, there's very clear data. Millions of people, pregnant ladies, have been vaccinated. It's been shown to be effective, and it's shown to be safe. There's no effect whatsoever so far on the outcome on the newborn. Okay, so as I said, ideally you should be vaccinated fully before you embark on pregnancy. But if you haven't been vaccinated, then get vaccinated. Okay, all three vaccines have been approved for pregnancy, but Pfizer has most data on the usage in pregnancy. So at the moment, our ministry is still using Pfizer for all pregnant ladies in all stages of pregnancy. Okay, now you may ask me, why vaccinate after 13 weeks if you say that it's safe in pregnancy? Why don't you do it at 8 weeks, at 9 weeks? Well, there's some colleagues of mine who vaccinated patients at 7 weeks, 6 weeks, 8 weeks, 9 weeks, and no untoward effect. We really have to look at the risk factor. If the patient is extremely high risk, for example, she has many comorbidities, hypertension, obesity, diabetes, then certainly you're justified in vaccinating them even at an early stage. The reason we postpone it till 13 weeks is that some, as you know, about 15% of pregnancies will miscarry, and if they do miscarry after vaccination, they would often put the blame on vaccination. So, I mean, as most of the most dangerous time where COVID affects pregnancy is actually the third trimester. So, if you can vaccinate at 13, 14 weeks, I think that's good. Like I said, ideally before pregnancy, but if you are pregnant, get vaccinated as soon as you find out pregnancy is stable at 12, 13, 14 weeks, then by all means, please vaccinate them. Okay. I hope the talk is okay so far. Now, the pregnancy has progressed. We've, at this stage, probably outruled any medical history. We've checked the baby's well-being, and the pregnancy is progressing. She's at this stage feeling better and not so nauseous and tired. And at this stage, we normally assess them, assuming there's no problems like bleeding or anything. Probably a monthly checkup is where we check the mother's blood pressure to make sure she doesn't develop diabetes. Hypertension. We sometimes do a glucose tolerance test to make sure she doesn't have diabetes. We also perform ultrasound regularly to check the fetal growth, well-being, and also for fetal abnormality. At around 5 to 6 months is when we usually do a detailed ultrasound to look for structural abnormalities in the fetus. And these are quite reassuring to both the mother and obstetrician to make sure the baby is well. But in the meantime, we should use this time when she comes to the clinic to check that the mother is well as well, both physically and mentally. Okay, and any symptoms, for example, abnormal bleeding or abdominal pain, should be assessed and managed as well. So I'm really talking about what we should do to help the mother deliver a healthy baby and herself being safe and reduce morbidity and mortality in the mother and the baby. So I'm just going through some of the things we look for, and then to actually prevent this sort of things from going wrong. And hypertension and diabetes are very common things that occur in pregnancy. Okay, there are two specific disorders in pregnancy called gestational diabetes and pregnancy-induced hypertension. These are specific, not the same as the normal diabetes in the other patients, and not the same as the essential hypertension you have in elderly people. Okay, gestational diabetes basically means you develop diabetes during pregnancy, usually after the 7th month, but it can occur earlier. Okay, and this is due to the changes in pregnancy, including certain hormones that makes you more predisposed to diabetes. Okay, and this diabetes may persist after delivery, or may improve and may even be back to normal after delivery. The importance here is that if it's not managed properly, and we treat usually with diet control and medications and sometimes insulin, and if it's not properly controlled, then the baby may get macrosomic, and there's higher risk of the intrauterine death, and also macrosomia, where the baby becomes extremely obese, and hence delivery is difficult and dangerous because you can get shoulder dystocia, postpartum hemorrhage with big baby, and higher risk of cesarean section because the baby is very big. Now, hypertension is also specific in pregnancy, where it develops again after the 7th, 8th month in pregnancy. From a previously normal tensive patient, they suddenly develop very severe hypertension, often associated with protein in the urine. Okay, and this can be quite serious, can lead to epileptic fit-like conditions in the mother, and also even stroke because of the high blood pressure. And it affects the baby in the sense that baby gets growth restricted. That means the babies don't grow inside, and they're very unhealthy. Okay, and the difficulty then in serious cases when developed but early on in pregnancy, the dilemma is when to deliver the baby, because the treatment of pregnancy-induced hypertension is not just taking medications to control the hypertension, but actually plan for a safe and optimum timing for delivering the baby and the placenta, which is the cause of the hypertension. So these are things we should really look out for and manage. And by managing diabetes and hypertension well, I think we can certainly prevent certain bad outcomes. Of course, anemia is another thing that we should look out for, and if we can correct the anemia before delivery, that's also a good thing. So we can give iron to patients who are iron deficient, okay? But don't overdo it when they're iron. I see a lot of clinics getting very excited with a slightly low hemoglobin of 10.8 and 10.6, and giving them parenteral iron and forcing them to take multiple iron tablets. In pregnancy, your blood will thin out. You get hemodilution, and so a patient whose hemoglobin is normally 12 or 13 or 11 and a half will drop to about 10.2, 10.3, and that's quite acceptable. It's quite normal. It doesn't mean she's iron deficiency. It's due to hemodilution. So sometimes we must not be too aggressive. On the other hand, patients who are obviously iron deficient should be treated with iron to maintain a good iron level at a safe level, because the patient will feel better. It's also safer to deliver a patient who has enough blood in the body rather than a patient who's severely anemic. Okay. We also, during the later part of pregnancy, want to look at the fetal growth by ultrasound, checking that baby is growing well. Not only the size, but certainly we need to look at the well-being of the baby. So other factors we look for in ultrasound is the umbilical artery Doppler, which is checking the blood flow in the umbilicus, and also the liquor volume, which is water surrounding the baby, which is basically urine from the baby. And if a baby is healthy, then there will be plenty of urine. And then if the liquor volume is sufficient, it's a good indicator the baby is healthy inside. Then in late pregnancy, we need to talk about the timing and the mode of delivery. This is the thing that patients are most anxious about when they start seeing you. They're thinking about delivery. It's such a you spend 9-10 months in pregnancy, and that little last few hours where you're talking about that seems to be the most sort of thing on their mind, and not surprisingly, because especially for first pregnancy, it's extremely stressful and worrying time. So it's very important to spend some time discussing with the patient the timing and the mode of delivery. Now, timing really depends on the condition of the mother and the baby. And of course, when there is hypertension, diabetes, insufficient growth in the baby, growth restriction, then certainly the timing needs to be earlier. Okay, we may need to bring forward the date of delivery to deliver the baby safely. Because if you leave a patient with pregnancy-induced hypertension and growth restriction in the baby and gestational diabetes to full term, then you're going to run into all sorts of problems. So very often we have to deliver the baby earlier. Okay. Now, assuming there's no problem, so of course there's no medical history, the mother baby is growing well and healthy, both are healthy and comfortable, then certainly the closer to term, the date of delivery, the better. Full term, spontaneous delivery will be the best. Okay. Now, then when is the best time? Patient always, when I'm going to have my baby? Really, you have to discuss, looking at the situation, which is the best way to deliver the baby. Okay. Now, there are three ways. One is to induce labor. That means by using medications or other methods, we want the labor to start, like going for natural labor, but to induce it rather than waiting for it to start spontaneously. So you're gonna induce the labor. Say, for example, a patient has mild pregnancy-induced hypertension at 38 weeks, want the baby to deliver before full term, we can always induce the labor if the cervix is favorable. Or if the patient has no medical history and the patient is comfortable, then you can wait for labor to start spontaneously. Okay. Now, there are some instances, of course, where it's not safe to deliver the child by the spontaneous or vaginal route. Okay. And in these circumstances, we may offer a patient to have an elective cesarean section. Okay. Now, for example, she has severe pregnancy-induced hypertension with growth restriction. For example, the placenta is low-lying, placenta previa. For example, is a huge, big baby, gestational diabetic with macrosomic baby, in the region of 4 kilos. For example, the mother is extremely short stature, and the baby is a good size. It's obviously cephalopelvic disproportion (CPD). Then certainly it's an indication to go for an elective cesarean. And an elective cesarean section is certainly safer than going for a natural birth and then not progressing and going for an emergency cesarean section, which is a bit more stressful and more dangerous. So these are the things we need to. This delivery timing and mode of delivery are very important things we need to discuss with the patient, and this come not just from the obstetrician, but from the patient to see what the patient expects or wants. Of course, within reason. There are certain instances where certainly going for spontaneous labor is not a viable option. For example, with a bleeding placenta previa, where you obviously need to do a cesarean section sooner. Okay, great. This should be really about labor, not late pregnancy. So now, assuming a patient is suitable to go for a vaginal delivery, and the patient is keen to go for a vaginal delivery, and there's no untoward risk factors that negates the possibility of a vaginal delivery, then she should be allowed to go into labor either spontaneously or we may induce it if necessary. Now, in labor, it's quite important to monitor the mother and the baby, the maternal and fetal well-being. I think it's very, very important. It's monitoring the mother and baby is not just with the medical equipment, but to have one person to be with her all the time is extremely important. A good midwife taking care of the patient, listening to her what she says, what she needs, someone to actually give her a bit emotional and physical support is extremely important, and it does help the mother a lot to have a sympathetic and caring midwife with her all the time, not one that just pops in and sees her every 1 hour or so to check the fetal heart. I think that's not acceptable now. I think in labor that she should at least get a one-to-one care at this stage. I think that's very important. Of course, sometimes we are short-staffed, but we should always do our best to give as much time to the patient in labor as possible. Okay. Of course, nowadays we tend to monitor the baby's heart rate by using a machine. We tie the thing, you can see in the picture there, we tie the thing around the abdomen. It's called a CTG, cardiotocograph, and it will just monitor the baby's heartbeat, and it will be printed out on a piece of paper. The pattern will be shown, and by looking at this, we can, of course, assess the well-being of the child in labor. That the stress of labor is not really affecting the child in a very bad way. But of course, CTG is open to interpretation. It's not the answer exactly, but this is what we have to know what's happening to the baby. And a very reactive CTG, where the heart rate is going up and down and with reactive patterns, is a very reassuring sign that the baby is healthy inside. We also monitor the liquor volume after the membranes have been ruptured. When we break the waters or the water break itself, we check the color of the liquor to make sure it's clear, there's no meconium. And then the other thing we need to do is monitor the progress of the labor. Now, painkillers, of course, we need to offer to the patient to keep the patient as comfortable as possible. We can give Pectidine and Nexlon. We can offer epidural in case patients that request it. And then we need to do regular examinations to see that the mother is making progress. That means she's progressing in the pregnancy, that there's a good chance that she will deliver normally. So we need to assess both the mother and the baby. Now, in some instances, despite all that has been done, unfortunately, the baby may go into fetal distress. The heart rate may drop, meconium may pass meconium, the baby, or the mother may not progress. For example, the baby may be too big, the mother's pelvis may be too small, or sometimes it's just unexplained and the progress. We can't leave the mother in labor for days and days like that in the olden days, So we need to offer them a cesarean section if, for example, we feel that the labor is progressing and the risk of continuing the labor is higher than if we were to proceed with a cesarean section. And if we feel that the risk is high, that if we proceed with the pregnancy, the mother or the baby may be at risk, then certainly an emergency cesarean section should be performed sooner rather than later. Okay, we don't want to wait until the mother is in a very poor condition or the baby is in a very poor condition before we proceed with emergency cesarean section. So if you need to do a cesarean section, do it early and on time, and not at a too late a stage. The anesthetic doctor and the operating room team needs to be informed. Even a pediatric consultant needs to be on standby in certain cases to take care of the baby after the child is born. And nowadays, of course, we know that thromboembolism is one of the main factors, cause of maternal death. Okay, and we do recommend some prophylactic anticoagulation after cesarean sections and high-risk pregnancies to prevent thromboembolism. Okay, it's one of the main causes of maternal death, thromboembolism. The other one is postpartum hemorrhage, and after the delivery, doesn't mean you deliver the baby either vaginally or cesarean that your job is done. You have to make sure the patients don't bleed. And one of the commonest causes of bleeding after delivery is after delivery, and they can bleed quite a lot. Okay, so you need to use drugs and to get the uterus to contract and reduce the bleeding after delivery. Okay, so we need to prevent thromboembolism. We need to prevent postpartum hemorrhage. We need to check on the mother regularly after delivery, make sure the uterus is well contracted. We have to make sure that the bleeding is less, that the mother's observations are good, the blood pressure, her pulse. These are all very important things that are to make sure that we do to make sure the mother and babies are safe. And I think that's about. Yeah, okay, almost. Very important. I'm finished. So the mother has delivered the child. The mother and child are both healthy, which is what really that we want. Okay, I mean, at the end of the day, all this is we want a safe delivery for mother and child. We want the mother to be delivered postnatally healthy and happy. Okay, and the child healthy. Okay, so postnatally, the mother and baby should spend as much time together for bonding. Breastfeeding is recommended because breastfeeding has been shown to actually improve the immunity of the baby. It should be recommended, and certainly it's good for the mother and the baby. Breastfeeding, okay. Now, for those that are obese, high risk, immobile, post-cesarean thromboembolism treatment with anticoagulation, early mobilization. I always tell my patients to be mobile. Some patients believe that after they deliver, they should just lie down and rest. I don't think that's a good idea. I think you should be mobile, and that will certainly prevent thromboembolism. Patients that have still not been vaccinated, we will get patients who have not vaccinated during pregnancy. You can vaccinate the day after you deliver. You can vaccinate during breastfeeding. You can continue breastfeeding during vaccination. The day you vaccinate, you go home, you can continue breastfeeding. There's no need to stop. Any vaccines are safe for breastfeeding. Of course, we need to then discuss with the patient about family planning, contraception. Not everyone wants to deliver 10 babies every 9-10 months. So we should offer contraception and family planning to them. We should not force it on them, but we should discuss it with them and the option giving to them. And maybe in these times of COVID, when things are tough, they may want to space the pregnancy a bit. They may need some temporary contraception before embarking on the next pregnancy. So at the end of the day, we want a healthy mother and baby and a happy family at the end of the day. So I think this concludes my talk. Do you have any questions? You can ask me.
Okay, thank you, Dr. George, for the very informative talk. Okay, we will now have our first questions from the audience, Doctor. Okay, we have one question from Kumisha and Dinesh. Hi, doctor. Good afternoon. Is it safe to conceive after the age of 45? Thanks.
Yeah. There are two answers to this question. First of all, your fertility will be lower after the age of 45. So if you can conceive, that's the first part of the question. If you can conceive, yes. Now, the second thing is, what is your general health at the age of 45? If you have no comorbid factors, for example, you don't have hypertension, diabetes, no other medical history or illnesses, then from the mother's point of view, delivering a child at 45 certainly is not a problem. Okay, if you're some patients at 35 are not even fit to have a baby, and some at 45 are perfectly healthy. So if you have no medical history, then certainly it's safe to conceive from a mother's point of view. Now, from the baby's point of view, uh, the risk of having a baby, for example, if you're 25, you have a child, the risk of having a child with Down syndrome is 1 in 1,000. At 45, you're talking about probably in the region of 1 in 30. Okay, so the risk of certainly having a child with chromosomal genetic abnormalities, including especially Down syndrome, is it's much higher. But saying that, we of course can uh, here is it. Of course, we can do tests for the baby. I've spoken early on about doing NICC, which is a test on the baby at 3 months pregnancy to detect any abnormal babies by doing a blood test. Okay. Now, in fact, now, say for example, you're going for IVF with the IVF centers at 45, for example, you're going for IVF. They can actually do pre-genetic diagnosis on the IVF. That means they can check that the baby is normal, that they can biopsy the embryo before they put implant into the uterus. So then you know that the baby is normal. So and that from that point of view, no problem. So if the answer to your question is it safe to conceive after the age of 45? The answer is depends on many factors, like I said earlier. Thank you.
Okay, doctor. We go to the next question, doctor. It's from Sharina. Hi, doctor. If a pregnant mother detected breast cancer at second trimester, she can continue with her pregnancy?
This is a very big dilemma in managing. So, like I said early on, before you get pregnant, you should always uh, check the breast, okay? Do a pap smear, make sure that you don't have an underlying problem before you embark on a pregnancy, okay? Now, for example, if it suddenly pops up, you have a lump in the second trimester, you did the biopsy and it confirms it's malignant, it's a real dilemma. It's something you need to discuss not just with your obstetrician, but also your breast surgeon and also your oncologist, okay? And whether it's what treatment do you require for this breast cancer, okay? Do you require mastectomy? Do you require chemotherapy, radiation, hormonal therapy? And whether the pregnancy can be uh, uh, you can continue the pregnancy uh, whilst all this treatment is ongoing. And this is not something I can just answer very simply, because every case of breast cancer is different. You need to look at the receptor status, you need to look at the stage of breast cancer. So this is actually a very, very difficult question. I've been unfortunate enough to have to deal with patients with breast cancer in pregnancy, and it's not easy to manage, because pregnancy does have a very bad effect on breast cancer, and it's not easy to manage. So, should she or can she continue with her pregnancy? Needs to be have a long discussion looking at the stage of the breast cancer, the receptor status, the treatments that needs to be done. It needs to be discussed with the oncologist and the breast surgeon and the obstetrician as well.
I see. Okay, doctor. So we go to the third question, doctor. If young lady pregnant with family history of Down syndrome, she need to do Down syndrome screening?
Yeah. Okay. As you know, Down syndrome, there are many different types of Down syndrome. It could be non-disjunction, it can be translocation carriers, okay? So she needs, if she's got a previous child with Down syndrome, you need to look at the genetic status, whether it's a non-disjunction or translocation. Now, certainly, Down syndrome occurs more commonly actually now in young ladies and old ladies, surprisingly, even though the risk of having Down syndrome is higher in older age group, but because more younger people have babies, and the screening for younger people are not as stringent as for older people. So you find that more babies are born to young with Down syndrome are born to young ladies than to old ladies, older people. So if she has a history of Down syndrome, then certainly there is a slightly higher risk she may have a child with Down syndrome. So when you say, does she need to do Down syndrome testing, this needs to be discussed in detail with the patient, depends to see what she wishes to have done. There's no need for anything, but certainly she should be offered Down syndrome screening. Because you must understand, when we screen for Down syndrome, we cannot change the genetic outcome of the baby. We can only tell you that the child has Down syndrome or Turner syndrome or Edwards syndrome, but we cannot make a Down syndrome baby back to normal. So, and if your beliefs are such that you do not believe in terminating the pregnancy, you do not wish to know you're going to deliver a baby irrespective of its genetic composition, then there's no need to do a Down syndrome screening. It's your choice. The choice has been made not just by the doctor, but by the patient and the family herself. But certainly, I would offer a young lady with a history of Down syndrome to do Down syndrome, because very often to screen for Down syndrome, we don't screen so that we can find something wrong with the baby. Sometimes we do the screening to reassure the mother for the next few months that she's going to deliver a healthy and normal baby. And sometimes just knowing that the risk of her having a child with Down syndrome is low, or other genetic disease is low, that is very reassuring to the mother. And that in itself is actually, so you don't need to do it, but certainly I would offer to the young lady with a family history, if she wants to do a test, which is actually just by ultrasound and a blood test, to reassure her for the pregnancy that the child is normal.
I see. Okay. So, doctor, let's go to the next question. Hi, doctor. May I ask, if my first delivery is C-section, can I go for a normal delivery for my second baby?
Okay. This one I have to first ask why you had a cesarean section for your first delivery. Now, if you had a cesarean section for the first delivery, it was uncomplicated. The reason was a non-recurring cause, for example, fetal distress or breech presentation, and this child is now in a head position first, cephalic presentation, and the baby is not too big, then certainly she can go for what we call it trial of scar. That you can try for a normal birth, but there's no guarantee you can have a normal, we say normal delivery, vaginal delivery. There's no guarantee you can deliver vaginally. You can certainly try if it's not a non-recurring factor. For example, if your first child was delivered because it was a cephalopelvic disproportion, in the sense that a 3-kilo baby could not come out due to the pelvis being too small, and this current baby is estimated at 3.5 kilos, then it doesn't really make sense to go for a vaginal delivery when the outcome is going to be the same. And we do know that an emergency cesarean section is 4 times as risky and more stressful for the mother and the doctor and the nurse than an elective cesarean section. So certainly if you have a recurrent cause, then I would recommend elective cesarean section, not to go for normal birth. But if you have say for example, your first child was delivered by cesarean section because the child was breech, and this pregnancy is cephalic and all goes well, there's no other risk factors, you're not 45, then certainly you may consider going for a normal delivery. We call it trial of scar, whereby we allow you to try, but if the the labor is not progressed, then you may need to go for cesarean anyway.
I see. Okay. Doctor, due to time constraint, we will have another one last questions from the audience. It's from Dina Lim Ailing. Hello, doctor. If a patient has already had 3 cesarean section from the previous pregnancy, is it safe for the 4th pregnancy?
Yeah. Before I came back to Malaysia, I've never heard of this rule of maximum 3 cesarean sections. This is a rule that's only, I think, in Malaysia. I've never heard of it. We used to do cesarean sections of 5th or 6th or 7th. You know, it's a patient's choice, okay? Now, but before I answer it so simply, there's no rule that you can't have a 4th cesarean section. Of course, after having 2 cesarean sections, most doctors will not allow for a normal delivery. You need, after 2 previous cesarean, the 3rd one will be 4th, the 4th will be a cesarean. They'll all be cesarean sections. Now, you need to look at your last few cesarean sections, whether there were any complications. If during the previous cesarean sections there were no complications, the adhesions were not too bad, the doctor who did the previous cesarean didn't tell you must not have any more children because of this or that, then certainly it's safe to have a 4th cesarean section. Assuming that's what you want, you know, to have another child. But there's no textbooks in obstetrics where say you can only have 3 cesarean sections. But it's something I heard since I came back to Malaysia, that you know, after 3 cesarean sections you must tie your tubes, and after a cesarean section you must wait 2 years before you can have another cesarean section or normal birth. These are something that's come up along, I mean, some aunties, and then aunties go to the health clinics. I don't know how, but this seems to be the advice that's been given to many people in Malaysia. But I don't see the reasoning, you know. If, for example, during your 3rd cesarean, the doctor told you, "Madam, please don't have any more babies because your uterus is damaged, the scarring is very bad, you know, we've almost damaged your bladder or your bowel," then please listen to the doctor and don't have any more children. But if they didn't say that, and then you can have 4, you can have 5. But the problem really now is not, is it safe to have a 4th? Can you afford to have a 4th baby now?
Okay, doctor. Thank you for the answer. But doctor, can we have like, can you answer one more last question?
Yeah.
Okay, one more. Okay. Does let me see here. Okay, does having endometriosis affect pregnancy?
Yes. Patients with endometriosis may have difficulty getting pregnant. Okay, because if you have endometriosis, it may block your fallopian tubes, so your fertility will be reduced. Okay, but the best treatment for endometriosis is pregnancy. If you do have endometriosis and you do get pregnant, that's a very good way to prevent the endometriosis from recurring. So certainly, if you have endometriosis, by all means get pregnant. Okay, ideally you can get pregnant naturally, but if not, you may need to go and see a fertility expert for assistance to help. If your tubes are badly damaged, you may need IVF, or you may need something to help with the fertility. But endometriosis does affect getting pregnant.
I see. That means always get pregnant if you don't want to get endometriosis.
Yes. The more
Okay, doctor.
pregnancy you have, the less endometriosis you have.
Yeah. Okay, doctor. So let us just wrap this Q&A session. Thank you, Dr. George. I am sure all of you had enjoyed this very informative talk by Dr. George Chan. Please stay with us now as we will play to you our closing finale video on a very beautiful poem entitled My Earnest Dream, composed by Miss Bridget Yu Yok Lin, our very own staff here in Hospital Fatimah Ipoh. Please sit back and enjoy. Bye, Dr. George.
My earnest dream. Lovingly formed I am for this world, residing happily in my mother's womb. My fate I shall wait, wondering what it's like in the outside world. Now COVID truancy has come to play. My fears, my tears, who will ever know? Will I make it out fine and positive so? With prayers, diet, and exercise, I will surely grow. Take care of me now, if you will, I believe. This is the best and what I need. Be born safe and healthy, my hope, not a scream. To call up mommy and daddy one day, that's my dream. Till then, I look forward to that day when the sun shines, smiles, and COVID hidden in the clouds. When I take my first breath and cry out loud. Thank you, one and all. Mommy and daddy, I love you all.
Thank you for watching. We have now come to an end of our series of talks and other activities in this Patient Safety Week, but nevertheless, not the end of our activities. As we invite you to further join us on Facebook and Instagram for our further programs. Thank you, keep safe, stay healthy, and have a nice day. Bye.